everyone. I'm Dr. Dong Yijie from Shanghai Ruijin Hospital, ultrasound department. Actually, I have already been working in ultrasound for 18 years. So today I'm very happy to be here to share our clinical application experience in our department. And today my topic is the clinical application of super resolution ultrasound in superficial organs. I just asked President Tian about how many doctors here already use super resolution ultrasound in your department. Can you hold your hand if you use this technology already? Few. Okay, so then I'd like to just introduce you these innovational technologies here. Actually, these technologies have some key steps. First is we have to use the injection of contrast agents, which is the foundation of the entire process. Because the contrast agents acts like a little guide, exploring inside the vessels. Can you see the bubbles here? Microbubbles within the vessels. And it is not only in vascular, but also can in lymphatic vessels or the gaps that the contrast agents can enter into it. Then we can use these technologies. Yeah. And then the ultra-fast contrast agents are collected by our probe here and providing rich data for subsequent analysis. And next, the microbubbles of the contrast agents are localized and attractive, just like tracking small targets. And finally, our series of formulas are used to reconstruct the super-resolution microscopy images. Although these formulas look complex, they are the magic spells for imaging reconstruction. So this technology features contrast enhance the imaging penetration, and super-resolution imaging penetrations allow us to observe superficial organs more clearly and bringing new possibility for clinical applications. Of course, now we not only have our superficial probes, but also have probes using in the deep side abdomen. We also have this probe. So today, I'd like to share these 6 aspects of my presentation. First is breast tumor. Because in our institution, we have our specialized aspects of breast and thyroid. Because our institution annually we have at least 4,000 to 5,000 cases of breast cancer. I mean surgeries, and at least 7,000 to 8,000 cases of thyroid tumors in our institution. So this is our 2 best specialized aspect, I think. Yeah. So first, the breast cancer. We are some major threats to women's health, and the super resolution ultrasound can play an important role in it. It can more clearly observe the characteristic of breast cancer lesions, such as the size, shape, and boundary of the tumor, and also help us to understand the blood vessel distribution within the tumor, and providing a more precise basis for the subsequent formulation of diagnosis and treatment plans. With SRUS, our understanding of breast cancer will be deeper and treatments will be more targeted. So let's see, this is a fibroadenoma. This is the benign lesions. We can see the distribution of microvessels are different from breast cancer. It's much plain and fewer and very smooth and regular. So this is a comparison of microvessel structure and spatial distribution between breast cancers and benign lesions. So these are very beautiful images and lets us to know more about the microenvironments in the tumors. So we also use this to do some research work. For example, in molecular subtype of breast carcinomas, we try to find if there's any differences between HER2 positive and HER2 negative breast cancers or some triple negative breast cancers. And we also try to explore, is there any differences between the proliferation of different breast carcinomas? For example, for Ki-67, the higher expression groups are different from lower expression groups. And then this is thyroid tumors. As we all know, papillary thyroid carcinoma is very common in clinical work. Actually, in our department, we do thyroid carcinoma ablations for over last year is over 2008 cases of thyroid benign and malignant tumors. I mean the ablations. And so the first is diagnosis. Of course, finally we will use fine needle aspiration cytologies to know the real pathology of each tumor. And the first is to evaluate how this tumor is located in the thyroid glands. Then we can do something more during the surgeries. Or in our department, because we do microwave and radio frequency ablation and laser ablations in our institutions every year. And the majority cases are thyroid carcinomas. Let's see the nodules that already been ablated. After the ablation, we can see the hole, a large hole. That's the right places. What previous is the tumor, but now this is the necrosis part. This is a benign thyroid nodules. We also can first do assessment before ablation, and we can see abundant blood supply within the benign nodules. This is a goiter, and after ablations, we can use SRUS to do evaluation to see if there are still some rest tumors here. Can you see it? This part. For ablations, because of the gas, the gasifications inside the tumors, then sometimes you will just hidden the rest tumors inside the nodules. So with the guidance of SRUS, we can do the rest parts of the ablations clear. The next is the SRUS in lymphatics. Actually, we know that we have two ways, using different ways of injections with contrast agents. we can have microcirculations including two dimensions. One is the blood flow and another is the lymph flow, which can help us understanding the sentinel lymph node situation from different angles. So the next part, let's focus on breast cancer sentinel lymph nodes. I don't know if any doctors know this technology that we can inject the microbubbles just intradermal. And in this way, we can have a very clear background of contrast enhanced images. And he can just show the lymphatic tract and the lymph nodes, but with no other complex background of tissues. The sentinel lymph node acts as the first lymph node to receive drainage from the primary tumors. And this is a very important step of a pre-operative evaluation. So serve as a critical basis for surgical planning. And we also know that for lymph nodes, actually there's two kind of metastasis. One is a micrometastasis, another is a macrometastasis. For macrometastasis, ultrasound already have very advantages to make differentiation of diagnosis. But for micrometastasis, actually it's very hard. So this is our intravenous way of injection. So we can see the cortex thickness. It's a 2.7 millimeter. But it's very hard for us to know if it's a real metastasis of a lymph node. So we use the contrast enhanced ultrasound and to reconstruct the SRUS images. This is the density map, this is the velocity map, and this is the direction maps. In these ways, we can just show intravenous way of lymph nodes. But just like what you have seen, actually by intravenous way, you also don't know whether it is a metastasis one or it's a benign one. But in this way, I mean the percutaneous injection of contrast agents, then I think this is a benign one. Why? Because all the contrast agents can enter into the lymphatic ducts and then just fall in the whole lymph nodes. That means this one is a benign one, not our metastatic one. In this way, we can do differentiation diagnosis. So let's see another case. This case also are lymph nodes. By this intravenous way, we can see this lymph nodes, although it's not very too large, not too big, but abundant blood supply in this. And also we can see the hilum here. The hilum is still in the lymph nodes. But is it a benign one or a malignant one? We don't know. But use this intravenous way, we can get very useful images of lymph nodes, but we still don't know the diagnosis. Then we use this percutaneous way. Then you can see actually the bubbles, the contrast agents, it's unable to enter into the lymph nodes. Only just the lymphatic ducts surrounded be enhanced, but there is a lackage of contrast agents within the lymph nodes. So in this way, we know that these lymph nodes must be metastatic one. Then let's talk about lymphoma. Actually, this is a real clinical diseases in some institutions, I think, but in our institution, we have a lot of cases. Actually, each year I have to do at least 700 cases of biopsy of lymphoma. I mean, not only diagnosis, but also biopsy. Because as we all know, lymphoma, we have to do corneal biopsy at least, or just let the lymph nodes just resected totally. Yeah. But lymphoma is very complicated clinical work, I think, because it needs a long process of diagnosis, and the treatment protocol is also very critical and needs precisely because it's an individual difference. Yeah. So for lymphoma tumors exhibit higher heterogeneity, but ultrasound findings vary among lymph nodes at different sites in the same patients, and even among different lymph nodes at the same site. Can you get it? I mean, even in one patient, because the different sites of lymph nodes, it can have different biopsy results. Yeah. Even in the same parts, for example, our cervical large lymph nodes here, each lymph node might have different results of biopsy. Yeah. So that's why we need very precisely diagnosis of imaging. Then you can have our real targets. This is very important. This is our lymphoma enlarged lymph nodes here. This is all lymph nodes. Then this is a thyroid lymphoma, diffuse large B-cell lymphoma in thyroid. So we can see the different maps of SRUS. This is the density map, and this is the velocity map, and this is the direction map and the angle map. And this is the short movie that's constructed by the SRUS. Very beautiful images, but how can we use it? This is SRUS in breast lymphoma. As we all know, lymphoma can just develop in every part of our body, except nails and here. All the parts we can have lymphoma. So we try to do something more in some research work because as we all know, conventional ultrasound are it's unable to differentiate different type of lymphoma because we have Hodgkin lymphoma, non-Hodgkin lymphoma. In non-Hodgkin lymphoma, we have at least more than 100 subtype of histology. So it's very hard. And we try to do something to use SRUS to do some assessment or evaluation just during the process of clinical flow. For example, in this case, these two cases, the first line is a male patient of 67 years old with primary margin zone lymphoma. So we can see these patients actually, the histology results just told us this patient has a lower Ki-67 proliferation expression. That means this patient is not so serious. Yeah. But the next one, the male patient with a younger age, but this is a primary peripheral T-cell lymphoma. And this patient has a Ki-67, 90% positive. So we just try to analyze, is there any significant of a parameter analysis that we can find to differentiate which lymphomas has a higher proliferation stage and which one has a lower proliferation stage. We can also use SRUS in systematic lupus. This is our a little bit large lymph nodes in axillary and with our thicker cortex and the higher blood supplies. So with the SRUS technologies, we can show the very detailed vascular distributions within the lymph nodes, and then use this we can also do biopsies. And now we also use these technologies to do some sclerodermal. This is a cases of younger patients. For this kind of patients, actually they are very anxious about their change of skin because the skin becomes very thick and dark. And actually there's a fewer treatment because fewer drugs can be used in this disease. So, and the evaluation and the assessments are quite hard. These days we are trying to do some cases of scleroderma, and we find the dermis exhibits are significant increase of blood supply. That's actually in conventional ultrasound or color Dopplers, we are unable to get these informations. We can only see fewer, very small diameter of vessels in the dermis, but use these technologies we can show. And this is another case. We can see the skin, the thickness is before treatment is 1.42 millimeter. But after treatment, we think there's the thickness decrease. This case we use our ultra higher frequency probe of 33. This probe, I think it can show the detail of skin very clearly. And this is the elastography, a straight elastography. And we can see there's a difference between the pre-treatment and the after-treatment. The images has differences. And for SRUS, I don't know if you can see, I think it's quite clear because before treatment there's a lot of blood supplies here, but after the treatment, only very fewer blood supplies. And we also do some cases of SRUS in testes. This is a case of a 39-year-old male patient who has had testicle swelling for over 2 years, but the patient has been holding on to a stance of complexity. He believed that this condition is a benign one, and he didn't receive any treatment for 2 years. But however, the images just reveal a significant tumor occupying a large area in both the testicle and the epididymal regions, or involved by the tumor. This is a diffuse large B-cell lymphoma in testes. We can also see all the parts of the testes just occupied by the lymphomas. But some part of the necrosis, very small part of necrosis within the testes. So for these patients, because every lymphoma patient have to do biopsy in our department, because we need the tissues, the fresh tissues, to do further examination, for example, genes. Some single cell analysis. So the fresh tissues are very important. Tomorrow, if some of you will come with me to our hospital, but this chance of I can just introduce these technologies because every day we use this in our clinical flow. Finally, is the multimodal US assessments in superficial organs. We think the precise guidance of interventional diagnosis is critical in our clinical work. Because nowadays, ultrasound doctors not only doing the imaging diagnosis, but also interventional diagnosis. And we think we can use this way, we can apply more detailed information pre-operation or even in some physical diseases, we can also provide the clinicians more information and assess the feasibility of puncture under different clinical needs. I think this is very important. And select the puncture targets. That means we should choose the most representative sites of each disease. For example, this is a 19 male, very young, T-cell lymphoma, but the patient has a mediastinal mass with extensive necrosis here, because we know that for not only Hodgkin lymphoma or non-Hodgkin lymphoma, actually there are many patients with mediastinal type with a large mass in the upper parts, and it can cause the respiratory problems. And for these patients, we can see there's a lot of necrosis in this big mass. But in the cervical parts, we can see these parts. There's no necrosis with high blood supply. And we think this part can also represent the whole body of disease progression. So we choose this place to do biopsy. That's the same. These are the two biopsy workflow used in our hospital for different organs, and we can choose different workflow. The first line is fine needle aspiration. Usually we can use in thyroid or metastasis of suspicious lymph nodes, because fine needle aspiration is very safe. I can do every part, no matter where it is, I can do. And the next line, the second line is core needle biopsy. Core needle biopsy is a little bit dangerous, but it is still very safe. As long as ultrasound can get the images, I can do this. Yeah. But we all know, because the core needle biopsy, it has injections just along the direction. So we should control. If the mass is too small, we have to do some technical guidance for them. So with these two international workflow, actually I think most cases of disease, we can have a biopsy in ultrasound departments. Only bone, lung, and some gastrointestinal parts, we might have some little problems, and pancreas. But actually in our department, we also do pancreas biopsy. Okay, so we just have a conclusion. For multimodal ultrasound assessment for superficial organ related interventional diagnosis and treatment, including breast, thyroid, lymph nodes, testis, and skin, B-mode, color Doppler, and now we have SMF, and elastography, contrast enhanced ultrasound, and finally SRUS. We can have a very precise localization and guidance for puncture and improve the biopsy efficiency. And then finally, we can have accurate evaluations. Okay, this is our team of Ruijin Hospital, that we have a lot of staff to do the clinical work and research work of SRUS. And you can see this is our young face. young faces. Yeah, I'm already an old one. And the future holds promise. And welcome everyone to come to our hospital, and welcome you to China to share with us. And we hope that we can have more chances to do cooperations together and to make our clinical work be better. Okay. Thank you.